Remember, close, close. Like, get it how close you want it to be, and then get it a bit closer.
So just yell out to me if you can't hear me. So I'm noticing that my presentation is straight after lunch, which can be the most difficult time for everyone to focus because we're all busy digesting our food. So hopefully you had enough caffeine and sugar to keep you going through my talk. So as we said, I'm going to be presenting some research on the burden and support needs of carers of people with personality disorders and some of the preliminary evaluations from some of the workshops we've been conducting. Some of this information may not feel new to you because most of you have some of this lived experience. I guess it's just numbers to validate what's going on for you in a way. And as we already mentioned before, kind of data informs change within the process, so I guess this is an important part of that. So first I'll be briefly looking at some of the preliminary workshop evaluations and then moving on to a study that we did looking more specifically at the burden and support needs of carers of people with personality disorders. So the workshops are continuing, and some of you who went to the workshop yesterday run by Emery and Tony would have got a taste of what I'm about to present. However, I've prepared some of the data for just to give you a snapshot from the carers who attended these workshops in 2012. So this is looking at 76 carers within 2012, and I want to preface this by saying that these were carers of people with any personality disorder. And one of the reasons for that is that personality disorders are often comorbid. Well, that's what the research shows. And what that means is that sometimes it's difficult for health professionals to tease apart what one personality disorder is to another. So someone who is diagnosable with BPD or HSS or however they're phrasing it may also be diagnosable with another personality disorder or features or characteristics of another personality disorder. So I guess it would be even harder for carers to be able to do that. So there's not a lot of support out there for carers of people with personality disorders more broadly, so that's one of the reasons we decided to do that. Also, these carers were anyone either biologically or non-biologically related to the person who just wasn't being paid for their role. So it could have been a mother, a father, a sister, a best friend, a flatmate, a significant other or spouse. So 68% of these 76 carers were female and 32% were male. On average, these carers were 53 years of age and had been within that caregiving relationship for about 10 years on average. And 100% of these, so 76 out of 76 of these carers said that they would endorse, recommend this workshop to a family member or a friend. And so at the end of the day, carers were given some evaluation forms, and these were some of the questions that they were asked. How satisfied were you with the workshop? And you can see there that 70% of the carers said that they were very satisfied with the workshop. Carers were asked, how helpful do you think this workshop was in increasing your understanding or knowledge of issues specific to personality disorders? And you can see 75% of the carers said that it was very helpful. And that 2% on the very right are just people who didn't answer the question at all, so they're not stated. Carers were asked, how useful did you find the workshop in improving your willingness to remain a care or support person to the person with personality disorder? And again, you can see the majority of carers said that the workshops were very useful in this regard. So what we were finding is that carers were saying these workshops were very satisfying for them, they were very useful in increasing their knowledge of the specific issues to personality disorder, and also useful in helping them remain willing to be within that caregiving relationship. We also collected some qualitative information, so basically we just asked an open-ended question and carers were invited to write down their thoughts. Carers were asked, what was the most useful part of the workshop for you? And some of this may resonate with some of what you've been saying today already. So one carer said, initially I was amazed that anyone would take a carer's opinion seriously because we've never experienced that in about 20 years of looking after the person with personality disorder. I could see that the people conducting the workshop were caring, and I could see that they were searching for a way to overcome the problem of feeling excluded from information, which I think is something that Eileen and some of the other carers today have been talking about. Another carer said the most useful part of the workshop for them was realising that they need to help themselves before they can help anyone else, which again I think is something that has resonated in this room today. Another carer said, I think the information in the workshop was helpful in all relationships, not just as a carer. having people who would listen, it's a part of the process of being encouraged. And another carer said the most useful part of the workshop was knowing that they're not alone, that there's plenty of help out there. So what we were finding is that carers were saying that the workshops are helpful for them. And so the workshops are continuing to be run. As I said, some of you were able to go to the workshops yesterday. However, I guess this is a small sample size of 76 carers, and we were really interested in finding out whether these opinions and views of these kind of local carers were more representative of carers of people with personality disorder more broadly, so kind of more internationally. And so that's one of the reasons why we decided to do this study on the unique burden and support needs of families and carers of people with personality disorder. One of the other reasons, which has already been touched on today, is that, as we know, psychotherapy is the treatment of choice for personality disorders. However, guidelines are now also recommending that we work with families and carers. So both the NHMRC more recently has said that, also the NICE guidelines in the UK in 2009. And I guess one of the reasons for this is that there's been a shift from treating people with personality disorders within an inpatient setting, so within a hospital away from the community, to now being treated within the community. And so with that comes the person with personality disorder residing with their families and friends and loved ones, placing more of the responsibility of caregiving with the families and carers. And so clinicians and researchers alike are coming to realise that carers can actually be enlisted as allies within this treatment. And so I guess with this thought, further understanding the actual experience of caring for someone with personality disorder may be able to inform treatment options or support options that the health service will be able to provide. So for this study, carers were invited to complete a survey, and we advertised kind of locally and more internationally. So newsletters, care events, educational presentations, websites, blogs, that kind of thing. So a lot of carers were asked if they would like to participate. Again, this is carers of people with any personality disorder because of the reasons I mentioned before. But also carers were again anyone who was in a supportive relationship with a person with personality disorder, either biological or non-biologically related. And that doesn't necessarily mean cooking and cleaning for that person, but just being within a supportive relationship and kind of aiming towards their recovery. So carers were included if there were carers of a relative with personality disorder, again relative meaning biologically related or non-biologically related, or they identified problems within their relative matching personality disorder features, even if they didn't quite know the particular diagnosis or name. And we compared what carers of people with personality disorders told us to publish reference points or benchmarks that carers of people with other serious mental illnesses have reported in the literature previously. So just to give you a sense of the measures, we use the burden assessment scale, and that's a measure of both objective and subjective burden. And by that I mean objective burden is kind of the everyday things that are disrupted from that caregiving relationship. So an example might be the household routine being upset, whereas subjective burden is more the attitude towards caregiving. So an example of that might be feeling trapped within that role. We also use the grief scale, which is measuring the grief associated with the mental illness of a loved one. To give you an example of what that question might look like, I get upset when I think of the family life I might have had this not happened to my relative, which I think is some of the stuff that's already been spoken about today. The Mental Health Inventory 5 is basically looking at the psychological well-being of the carer, so looking specifically at depression and anxiety symptoms. An example question of that, have you felt so down in the dumps that nothing could cheer you up? And the difficulties in emotion regulation scale was also looking at psychological well-being for the carer, more looking at kind of emotional awareness and access to emotion, emotional clarity, that kind of thing. An example question of that might be, when I'm upset, I become angry at myself for feeling that way. So just to give you a bit of a sense of the measures that we used in this survey. Next slide. So 474 carers consented to participate in this survey. 187 were excluded for various reasons, such as not completing any of the questions or not having a relative, biologically, non-biologically related with personality disorder. So in the end, 287 carers were included in the study. And I just wanted to give you a bit of a sense of who these carers actually were. So on average, they were about 47 years of age. On average, they'd been within that caregiving relationship for about 12 or 13 years. They were mainly females, mainly full-time employed, mainly mothers or partners or spouses, so a bit of a mix there. And the people with personality disorder, to give you a bit of a sense of who they were, on average, they were about 40 years of age. They were mainly females, mainly unemployed. To the carer's knowledge, in the past year, there'd been on average 1 hospitalisation, and to the carer's knowledge, within the past year, there'd been about 11 days involving deliberate self-harm, and within the last year, to the carer's knowledge, there'd been about 2 or 3 days involving attempted suicide. So I guess looking at the results, I don't want you to concentrate too much on the numbers because I'm going to try and decipher what all this means for you. I've also got some qualitative information again from the survey. We asked an open-ended questions and carers were able to write down their thoughts, and so I tried to pick quotes which were depicting what the numbers mean, or at least what I interpret them to mean. So what we found for the burden assessment scale, if you remember, that was looking at the objective and subjective burden experienced by carers. What we found was that carers reported to us statistically significantly higher burden than previous research with carers of people with other serious mental illnesses, including schizophrenia. So basically what this means is that carers of people with personality disorder are significantly burdened, both objectively and subjectively. And I think we've already alluded to that today. So I guess a quote which I thought kind of captured this. Every step I take could have consequences, and so I had to learn to tiptoe around issues and give up things whether I wanted to or not. I suddenly had to become more of a father figure than a lover, taking time off of work to take her to doctor's appointments because she couldn't go alone, something I never thought I would do for another adult. So I guess within that you can hear the objective burden involving taking time off work, arranging appointments, those kinds of things, but also the subjective burden because this particular individual kind of sounds pretty dissatisfied with the relationship and almost kind of trapped. The grief scale, which was looking at the grief associated to the mental illness of a loved one. So what we found kind of, again, was that carers of people with personality disorder were endorsing scores statistically significantly higher for grief than carers of people with other serious mental illnesses have done in the past. Again, including disorders such as schizophrenia. So basically what we're saying is carers of people with personality disorder are significantly burdened and also significantly grieving, potentially more so than carers of people with other serious mental illnesses, which I think is something that I've heard already today. An example quote of that. The biggest impact has been the grief of losing the person my daughter might have been and the heartache of seeing her suffer. My life has basically been on hold, hoping she will get better and become independent, and now gradually realising this probably won't happen, and starting to accept that I may have to care for a long time with someone with what I'm starting to consider as a disability. So I guess within that you can really hear the grief not only for the loved one and the life they may have had this not have happened, but also the grief for the carer's own life and the turn that it's taken within that caregiving role. So the mental health inventory 5, if you remember, was looking at psychological well-being for the carers, in particular looking at depression and anxiety symptoms. And what we found is that on average, carers of people with personality disorders endorsed scores on this measure that kind of indicated they were experiencing clinical levels of depression and anxiety symptoms. So I guess not only are carers significantly burdened and significantly grieving, potentially more so than carers of people with other serious mental illnesses, but they're also having kind of to tackle their own mental health difficulties within that. So a quote, when things are going well, I'm going well. When my daughter falls in a hole, so do I. Even though I feel I've been doing this caring for so long, I should be used to it. So I guess you can really hear in there the ups and downs that come along within this caregiving relationship. The difficulties in emotion regulation scale, if you remember, was also looking at carer psychological well-being, but more around kind of emotional clarity, emotional awareness, those kinds of things. And what we found, which was a particularly important finding, I think, personally, is that carers of people with personality disorder were endorsing scores on this scale which are similar or kind of comparable to people who have been diagnosed with clinical post-traumatic stress disorder. Yeah. Pretty powerful finding. So the way that I interpreted this, and the way that I think some of you would, judging from Aline's talk earlier, is that carers of people with personality disorder potentially may witness very distressing or disturbing behaviours in their loved one. And by that I mean attempted suicide, self-harm, impulsive anger, drug use, impulsive risk-taking behaviour, all those kinds of things, which I imagine would be very distressing to witness within someone you love very dearly. And so we were thinking that this is probably indicative of carers of people with personality disorder experiencing some level of vicarious trauma through that caregiving role. And an example quote that captures this a little is, "It makes your heart hurt and causes you to take a bit of distance when you look at the suicide rates for this disorder and talk about the real potential to lose yourself to suicide." And I think within that you can really hear the heartache of this person. However, I think it's also important to give a voice to the carers within this study, within this survey, who reported more positive kind of caregiving experiences. And I guess this is alluding to why we're all here today. We're all here because we believe in the potential for recovery for people with personality disorders. And we believe that there is potential for quality of life improvement in these people. And we're here because we believe in persisting as a carer and the healing potential that that may involve for the person that we love. And a few of the people who responded to this survey spoke to that, and it's important to give them a voice. And I guess this all depends on where the carer is in their own journey of caregiving and where the patient is in terms of their recovery. But I guess it's important to kind of acknowledge that side of the story too. So I think this is a powerful quote within that. "During his childhood years, it was very difficult and his behaviour disrupted our home and family. I thought his behaviour was my fault. He then got into counselling and began to rebuild his life. He's making much better choices and I see improvement over the quality of his life. My son is grateful for my support, tries and accomplishes tasks on his own, has a job and has purchased a home. He's a strong young person that handles his mental illness. It's unfair to see him struggle, but I also know that life is never fair. We just have to deal with it." So what does this all mean, I guess? Well, what we found within this study of kind of a large sample size of people, broadly speaking, internationally and locally, carers of people with personality disorder reported to us experiencing high levels of burden and significant levels of grief, potentially more so than carers of people with other serious mental illnesses, including schizophrenia. These carers also reported experiencing their own mental health difficulties, including symptoms of depression and anxiety, and potentially even post-traumatic stress. What we know is that families and carers are the most consistent resource for the person that they love with personality disorder. They're the ones that are there most hours of the day. However, if these carers are significantly burdened and significantly grieving and experiencing their own difficulties in mental health, it is possible that they'd be less effective in their role because they'd be so overwhelmed with what was going on for them underneath their own skin. And so I guess what we took away from this is that it really highlights the need for clinical interventions to support families and carers so that they can best support the person that they love, potentially for good outcomes for all. And I thought I'd end just with one more powerful quote. For me, this one really speaks to what we've already heard a little bit today, is that carers really want to help and they want to be there for the one that they love. Yet they also want to maintain their own well-being. And I guess that's, from what I've heard from carers over the last 3 years, that's one of the largest of the carer struggles, is how to maintain their own well-being, their own sense of self within that, whilst also supporting the person with personality disorder. And I guess that's one of the main aims of the workshops that we've been running. So that's kind of how that ties in. So my husband and I have made mistakes, but not with any bad intentions. Yet we keep on hearing that BPD is due to trauma and abuse caused in early childhood. This paints all carers of someone with BPD as somehow being bad, and yet the parents that I know love their daughters and are desperate for some sort of help and understanding of the illness. We want to know how to help, yet at the same time keep our sanity by setting suitable boundaries. And I guess from what I've heard today, that kind of sums up kind of the carer's struggle. And I hope that that's representative of your experience. Thank you.
Thank you so much, and there'll be an opportunity, as I said, to ask questions shortly. It is interesting, isn't it, that the anecdotal experience we heard earlier in the day is so closely mirrored in the studies. I suppose that's logical, but nonetheless, and it's such a difficult and wonderful role, caring, isn't it? And I say wonderful, I mean wonderfully indicating what a wonderful character of the person doing it. Like, I'm doing it for 3 people at the moment, but just because they're kids. You know, like, when they're adults, I'll be... You know, I mean, it's a huge thing, isn't it? Because you do it for your kids and you care for them, but in a way, every year you have to care in the sense of providing services less and less. You know, when they're a baby, you have to do everything for them. When you're 10, you have to do less. When they're 15, you have to do less. I mean, you still have to do a lot. But it is less. When they're 25, ideally less. And so you sort of see the intense care you do for babies tapering away in a very satisfying way, normally. But for it to continue when people are 20 and 30 and 40, it's just an amazing thing to do. And I guess people don't often feel they have a choice, but that makes it no less admirable, in my opinion. Let's turn our attention now to consumers. We're going to hear from Chris Willcox. Now, he's the principal clinical psychologist and head of Hunter New England Mental Health Psychological Training Program. He's also an educator with the Hunter New England Training Program and a senior lecturer in psychology at the University of Newcastle. You notice that pretty much everyone we've got up today has about 5 jobs. It seems to be particularly dependent with the medical profession. You never hear, yeah, he's a doctor and he works there, or she's a doctor and she works there. They always have about 8 different things. And they must, you know, I hope they, you know, well, either you work very hard or you know, they're all overpaying you. Because you're only there a third of the time. Chris has over 20 years' experience working with those with personality disorders, including borderline personality disorders. He's going to talk a little bit about what he's learned. He's not overpaid. No matter how much he's paid, he's underpaid. Please make him very welcome.
I've been sitting up the back all day and James said I'd better come down here, otherwise I'd never get down here in time to give the talk, and I said, yeah, that's a really good idea, that'll stop me telling you jokes about me on the way down. And you promised he would beforehand.
You planted something in my head.
That's right, it's all my fault. Look, I've popped this slide up here, as you can see, and I've crossed out dialectical behaviour therapy. Very early on in the program, one of the people renamed it as diabolical bloody therapy. And what she was kind of capturing in that is that DBT actually requires an awful lot of the people who engage in the program. And we talk about this very early on with people in terms of we're going to be expecting an awful lot from you and we will give an awful lot. And I guess DBT is very much a collaborative model where there's an awful lot of work done and it's based around the absolute importance of the therapeutic relationship. In terms of the study that I'm going to talk about here, I'm going to be talking about part of a study, and the study was actually done by Mel Moran, who's the second name there. And she did this as part of her master's thesis for her clinical psychology qualifications. Mel's not here, but was more than happy for me to talk to this. And in terms of this, I'm just going to be trying to capture both her words in her thesis at various stages and also the words of the consumers that she interviewed. So this is going to be a little bit like Death by PowerPoint, and it's going to be much more texty than I would normally do. But I'm trying to capture words of consumers and her words as part of this. Now, one of the things that makes me emotionally dysregulated is when I come to a conference and I expect that I'm going to be sitting here with a laptop in front of me and I'll be able to see what I'm talking to. So I arrive at this lectern and there's nothing here. It's all there. So somehow I'm going to have to find a way of not turning my back on you and trying to talk to what's on the screen. So I kind of apologise. And the other fear, of course, I have is that I'm going to fall off the stage as I turn around and do this. But we'll kind of see how we go. Okay, in terms of the plan then for this talk, this is a sub-study overview and I'll get to that in a moment. There were a number of themes that came out of this, and they were living with borderline personality disorder, the services that people have bumped into along the way, thoughts about DBT and thoughts about their own future. And then at the end, I've put on a section there. So kind of in response to this study, but also in response to feedback that predate this study, what are the changes that we have made to make services more accessible along the way? And so that's just the name of the full study up there. In terms of the participants in the study, so this was very, well, not that early on, but done a number of years ago. We followed up the first 190 graduates from our DBT program at the Centre for Psychotherapy. And then in terms of numbers, Mel didn't get an overly good response, but then she hadn't worked with a lot of the people, so I then rang some of them. And we ended up with 35 people who said that, look, they'd had the time and were happy to participate. We did some initial interviews with those, and that was what formed the basis of the questions that we used in the focus group. So we're kind of 2 steps to this process. This is really funny, I must admit, having somebody else change your slides for me. In terms then of what we did, we had some semi-structured interviews. So there were 3 open questions by way of example. How would you describe borderline personality disorder to someone who does not know what this means? In terms of service provision, we gave them a scale which they could mark from extremely negative to extremely positive. And for instance, would you rate your experience overall with our mental health service? And then questions around treatment issues. We had 8 questions there. And for example, what was your opinion of the DBT program? Because this, I guess, is what we were really trying to elicit, but we elicited some other material along the way. Okay, we then analysed the questions. I'll get through the study fairly quickly. And as I said, in terms of the areas that fell out, you can see them up there. So it was living with BPD and then both on impact on self and others. In terms of accessing services, so what's been their experiencing access services in the community in various shapes and forms? What's their involvement with community health services been like? And then what's been involved with their inpatient programs? And then finally around the DBT program and the future. So these are the first few comments around, well, what's it like to have borderline personality disorder, so impact on self? It's like being on a roller coaster and everyone else is catching a train. I'm really kind of aware in reporting some of this stuff that given in the audience we have consumers, carers and clinicians, that for some of these slides people are going to go, yeah, I know that, but I'm hoping that for other people in the audience, we, oh, really? And so that's how I'm hoping that overall we will kind of go with this. There'll be some stuff that you know, and that's a little bit like when we teach DBT skills. We're really aware that some people know the skills and use them, some people know a skill but don't use it, and some people don't know, don't use. So I'm hoping the presentation is going to be a little bit like that too. So a second quote, the range of emotions are outside the norm, and I didn't know how to exist within a smaller range. So at some point you have somebody coming along and saying, look, I'm really struggling with how I'm living my life, but I don't know how to live it any other way. And really aware that when it comes to any form of change for anybody, that when in doubt, we go back to what we've done before. Even if we're kind of saying at a head level, this doesn't work for us, in terms of that kind of gut felt experience, the responding to life, we go back to where we've come from. So this can, while wanting change, it can also be really difficult. And then just a comment, which we know, it's so broad, the diagnosis. No 2 people with borderline personality disorder have the same symptoms. Everyone has the same stuff. I mean, in terms of if you look at the DSM, I mean, there's a whole range of things that we can criticise it for. And one of them is that, you know, you have to meet 5 of the 9 criteria to have borderline personality disorder. Arithmetically, that means you can meet that criteria 128 different ways. So I'm really aware when we use this term, borderline personality disorder, that it's kind of very much a catch-all phrase. But the idea that if you have borderline personality disorder and you have it, that you're somehow both the same is absolutely ridiculous. But what is an attempt to kind of capture a description of some things that are in common that people struggle in and around. I mean, the earlier comment by Janelle about changing it to HSS, on one level I absolutely love it, but on another level I'm aware that I struggle with those letters because it also stands for Health Support Services. And Health Support Services, if you work in the public service, is a bit like the Ministry of Peace. For those who have read Brave New World, which obviously is about war. But what the heck? Can you explain? Okay, in terms then of the impact on self, so the majority of participants had a good understanding of the criteria, but said, look, our main problems are being our mood swings, emotional sensitivity, and managing urges to self-harm and attempt suicide. And what I've just popped down the right-hand side of that then is to say, look, coming from a DBT perspective, DBT conceptualises borderline personality disorder, or HSS, as being a pervasive dysregulation of the emotion regulation system, so it's kind of what happens when there's no monitor up here. And then with skills modules then that focus on emotion regulation, tolerating distress, and relationships with others and self, and our primary targets are suicide and deliberate self-harm. Now this is very much coming So DBT was developed by Marsha Linehan. Apart from being a very bright kind of research psychologist, she also had borderline personality disorder in her younger days, and it's been a couple of years at one stage in an inpatient unit. So she very much arrived at this with the lived experience. And so what she was able to do was put together her lived experience and the fact that she managed to survive it with a very bright mind and a very kind of rigorous approach to research. And so she very much takes an approach, well, what the data says is correct. She kind of able to, and so in terms of developing the dialectical behaviour therapy, it was very much driven by the research, her taking her work, other people taking their work, and kind of looking at what worked and what didn't. And then the theory kind of came behind the practice. Other things in terms of impact on self, so issues were raised about being labelled and the stigma that came with this, and people have mentioned this along the way today. Most were accepting the diagnosis, describing it as a relief that they were not alone, and that certainly has been our experience, that while people are aware of the stigma attached to the label, to be honest, the stigma exists most in the health service. And so people, I mean, I'm aware that, so as consumers in our program, we've had trainee health professionals from all the health professions you can imagine. And somewhere in their first years, they pick up the stigma related to borderline personality disorder. Now, I've got no idea how that happens because on one level, borderline personality disorder generally isn't taught in the first year of any of our health programs, but there is enough of that historical stigma coming through somewhere in these programs that people are very much aware of. So we find that some of the people who, if you like, fight the label strongest are the people who are already bumping into the stigma most because they're in training programs. Equally, we're also really aware that a lot of people are kind of like, oh, thank God for that. Somebody finally knows, you know, what's happening for me in the sense of, okay, because what's happened is, once again, it's been referred to today, that often people don't want to use this label because they're aware of the stigma that comes with it. Historically, this is a diagnosis that has led to an exclusion of treatment. You know, historically, you know, people with borderline personality disorder are seen as being untreatable. They're not our core business. They're not Axis 1. You know, get this bloody PD off my ward. If they really want to do, you know, all those sorts of various bits and pieces. And so, in some ways, people have tried to be kind by not giving a label that leads to exclusion of care, but equally, it then did lead to a treatment. And so, historically, our services, I think, have been very good at providing a service, but not a treatment. And this is a process that really, irrespective of where DBT goes as a model, I mean, I think one of the things that it's done is change the belief about this particular patient population that indeed, you know, this is a disorder that is treatable like many other disorders, and as has been presented earlier on, it's one that has some lovely outcomes. But mental health services are still struggling with that in some shapes and forms. In terms of the impact on self, so most said, look, it had interfered with their study, with their work in various shapes along the way, and I'm just going to jump from that slide at this stage. Now, in terms of families, and so if we think about families, once again, if we think about history around this, there was a point in time when people used to talk about the schizophrenic mother, not meaning the mother with schizophrenia, but the mother who created the child with schizophrenia. As that kind of disappeared as into folklore, what seemed to start popping up was this idea that somehow people with borderline personality disorder came from these families that had somehow created this disorder, and they'd somehow created it by being parts or aligned with abuse, shaping various shapes and forms. Once again, it's starting to go the way of the idea of the schizophrenic mother, but it's still out and about, but I'm aware that it's not as strong as it was. And I guess one of the nice things about this, and this is really about then talking to clinicians about, you know, people's relationships with their family. So the majority said, in terms of their family, that they were very supportive, though not were all as supportive as each other, which is reasonable. You get different levels of support from different folk. Family and friends were described as having a limited understanding of borderline personality disorder, which once again is reasonable. The mental health profession has been struggling with an awful long time. About half felt this was a resistance to learning and caution about multiple and or other diagnoses. And I think once again this captures the history in mental health to some degree, that we're aware at the centre, people will often pick up other diagnoses along the way. And so they will pick up a diagnosis of depression or bipolar or some form of psychotic disorder, and eventually somebody puts all that together and goes, well, if we put this cross-sectional view with this one, hang on, we've mostly got it wrong along the way. So The sense being that, well, families have kind of studied up on depression, they've studied up on this and that, etc. on the way. Look, that's fine. Thanks. If you want to go to the next slide. But having said, look, maybe my family doesn't know as much as I would like them to know, the majority felt that having a supportive family was much more important than having a knowledgeable family, even if that sometimes meant they felt a bit misunderstood. And I'll talk about our family group later on. In fact, most recognised how lucky they were to still have their families there with them, given the many times that they'd gone through the hard times with them. And just a couple of quotes there, you know. I tried to run my husband over once. I'm not sure how long I'll stay with my wife. She tried to run me over. Fortunately, we haven't had that test as yet. It's been incredibly difficult for my parents. So just recognising how hard that pathway has been along the way. If I didn't have those parents that I had, well, I'd probably be dead. And once again, just capturing the absolute importance of the family. Now we jump across to their experience of services in the community. So this is just kind of a quick jump process. So in terms of their experience with emergency personnel, so in this case the police and ambulance, people describe the opinions of these folk as changing once they knew something about the mental health of the person accessing the services. And most believe that the police and the ambulance services had a very limited understanding of mental health, mental illness in general, and BPD specifically. And certainly there are programs being driven to educate the police force, but the rate of training around mental health issues is actually running a bit slower than the rate at which they retire. But, you know, so part of it, you know, is we need to put a bit more pressure on in and around those sorts of things. But in terms of borderline personality disorder, really aware that the biases that live within the health system sometimes then transfer through to ambulance and police in various shapes and forms. And then there was a theme coming through about the limited knowledge and experience also in general practitioners and with private psychiatrists, and they described this as being a punitive approach, leaving them feeling like an illness rather than a person. Most felt that as teenagers they were mostly not listened to by health professionals, and those who, however, counterpoint to those who felt they had a general practitioner with experience in managing borderline personality disorder believe this made a huge difference. So if you have somebody who's there to advocate for you, and indeed one of the things we've been doing through the local mental health professional networks, which is engaging with GPs and a range of other health professionals, is we've been doing some education in and around borderline personality disorder. In terms of then our community mental health services, they all felt there was a lack of resources affecting how they were treated, i.e. they were being treated as a lower priority. And in periods of crisis, stereotypes became very strong and they were treated as a borderline rather than an individual with distinct problem areas. Working in the public mental health system, I'd like to say that's not true. I feel a bit defensive when I read some of this stuff, but the reality is that's where it sits. And so from my point of view, I've got then a responsibility to change that culture. So that defensiveness, I guess, motivates me to try and change some things, and we popped some things into training in and around that. They also said that, look, regular staff changes and the disruption that this caused was also a common theme. This was particularly with the psychiatry services and the acute care services. So a couple of comments on that. Psychiatry registrars rotate as part of their training program, so if you're linked with a psychiatry registrar, then obviously you're going to lose them at some point. And also our acute care services tend to be on rosters, and so the chance of getting the same person rostered on is difficult. So we're aware that there's that break in service that's going to occur there really regularly. Those who had access to community mental health services found that the therapists were the people who assisted the most and understood them the best. Now, just to talk, in Hunter New England, the way we organise our community mental health teams, we have acute services, and so this is where they're talking about the acute care service, but we also have therapy teams. It was something that we did now about 15 years back. We said we wanted to get away from generic mental health workers. We actually wanted to use the more specific skills that people had. So each of our community mental health teams then has a therapy team embedded in it. And so really, if you come down to function, what they're saying is right. Those people who are there to provide therapy, they're the people we get to develop better relationships with. Therefore, they're the people that we get to kind of work through our issues and work towards change with. And I'll just an aside, I'm aware that a number of the local health districts don't organise their health services that way, so essentially everybody's going to be providing a care coordination or a case management. In terms of inpatient services, the majority stated that their reason for going to hospital was not because they wanted to be there, but because they did not feel safe in the community. Once again, I think this is an important mission more out to clinicians. Because, I mean, I come down, my kind of take on this is, if I wanted to be in a mental health unit, then things must be really, really crook. Because if I think about all the places on the planet I would like to be, it wouldn't be one of our acute units. Most found the inpatient environment frustrating and confronting, with one describing her admission as horrific and like being in jail, and themes around dehumanisation, judgment and validation are prominent. As I said, there's part of me that's really bloody defensive about putting this stuff up, but that's the stuff that came through, so that's the stuff that we have to go about changing. In terms of, so the most common theme was that of nursing staff made them feel they were not wanted there. I just want to kind of protect my nursing colleagues though to some degree. I'm aware I worked in a therapeutic community for a number of years, and the main staff there were nurses, and they provided wonderful care. In fact, I've bumped into an old colleague who is sitting up the back. But I'm really aware that in our acute units, once again, it comes down, some of the feedback with this comes down to what the roles of the various people are. So you'll see that they felt that part of the problem was that there was no psychologist or other supportive staff members there available to speak with. The way our acute units are staffed, there is one psychologist, and so that psychologist has a degree of freedom to range to some degree and provide services, but there's certainly a shortage of them. Others felt that some staff had no empathy for their problems, and if I think about some of the staff I've bumped in over the years, I think that's a very true and sad statement. A common theme, though, was that allied health staff provided the most support because they had a better understanding of BPD and a more natural empathy for them as people. Once again, I think this partly comes back to role. Okay, so given the often negative perception of hospitals, some admitted to lying about the risk of self-harm and suicide in order to be discharged. This is a message that I've tried to convey out to our staff, because often our inpatient units, we're really pressed for beds, we're really pressed for numbers. And so if somebody kind of says, look, I'm happy to go, then it's kind of like, great, I'll help you pack your bags. And what I'm saying is, look, with people with borderline personality disorder, just do a double check. We may actually be increasing their risk at that very moment. Now, this is kind of counter to how our services work, but just saying, look, you just need to be a little bit careful about that. Now, the other end of that is there are others who admitted to amping it up or pushing the envelope in response to negative ways in which they were treated. So indeed, some of the stereotypes do play out. The stereotypes play out in a context where people are sort of being told, well, you shouldn't be here. And one of the ways of responding to that is to kind of fight back. I mean, I know one of my responses to being under attack is to attack back. So I'd be one of the people, I think, who would amp it up or push the envelope, which is mostly why they haven't admitted me. Okay, so all participants, they stated they valued psychological interventions more highly than medication. And if you think about the comments earlier on today about the role of medication, what we know is that there's no medication that treats borderline personality disorder, though people may have coexisting conditions. So although medication alleviated some of their symptoms, they generally felt that side effects, temptation of overdose, non-compliance and polypharmacy led to subsequent problems. And I think this is a message that we within the system need to get much better at getting out to the people who have control of the medications. Because I think sometimes people end up with medications because it makes the prescriber feel better. But it may not be the right thing to do with the person who's having prescribed for it. Now, if we jump through the DBT program, so as I said, this is a bit of a jumping presentation. So participants felt that being non-judgmental was the most important attribute. Others included warmth, knowledge and being approachable. And certainly one of the things that we really focus on is taking a non-judgmental stance, both as a therapist but also as the consumers, in terms of a very useful skill to learn along the way. And certainly as a DBT therapist, I'm in a consultation group every week, and we see that as being DBT therapy for the DBT therapist. So in essence, it's about how do we live the model of therapy that we teach and practice in. Most interviewees felt that they formed such a close bond with their therapists that they were constantly afraid they would disappoint them and be a failure to them. This feeling was the main reason why they became determined to not quit the program. And we're really aware that in terms of leverage, there's only two pieces of leverage really. It's what the consumer wants and the quality of the therapeutic relationship. And so we very much view this as a relationship between equals where we have an influence on one another. And we're also really aware that in terms of that relationship, that one of the reasons, for instance, people will give up self-harm is that they don't want to disappoint their therapist. You know, it's not necessarily something they want to get rid of in some cases, but having got rid of it, we often then find people pine for wanting to, you know, I'd love to be able to self-harm again, but having lost that kind of as a solution, it seems to be a solution that many can't find their way back to. Next slide. So then a few quotes. I think that rapport is really important because there were times when I hated that woman, absolutely hated her. And this kind of captures out that it's, in times in therapy, there's a whole range of strength of emotions and things that play out, and really you've got to have that good, collaborative, therapeutic relationship to get in and around those humps and bumps. And certainly you'll get a strength of feeling also coming from therapists, and once again that's where our consult comes in, that's where we go to talk about where we're struggling around that. At times we'll also bring up with the use of immediacy in therapy. And the next quote, even more so, there were times when I could have gladly hung her up by her toes. And with the self-harm, I couldn't bear to see the disappointment in her face when I turned up my arm bandaged. So you're capturing both sides of that. At one point, some of the things that were being asked of me were to the point where I wanted to string my therapist up. But at other times, look, I really didn't want to disappoint her. And we're going to see that kind of bounding backwards and forwards occurring within the therapy early on. In terms then of the DBT program continuing, so fabricating information was also a common theme, mainly related to self-harm. E.g., one participant admitted to lying about the frequency of her self-harm in the initial interview, as her referring agent had recommended her to do it. Now, her and the referring agent were actually being quite bright. So the Centre for Psychotherapy, when we first set it up, we only had 4.5 clinical staff. We've got about 10 of us now. But the reality is, at this current point in time, we split our time between eating disorders and personality disorders. And in terms of the personality disorders section, we've got about 100 people with borderline personality disorder. So we are a limited resource. So we have some inclusion and exclusion criteria, and it's kind of out and about how many times you have to have self-harmed, and so some people will lie to get into our program. At some point, I can't blame people for doing it. You know, if this is what I have to do to access a service that I think can be helpful, well, so be it. Also aware that people lie about where they live. So we've got a health district below us where people will find a friend or a family member that lives within the Hunter New England district, and they'll give that as the address. Or they'll just come up with a fictitious one, which we discover when we send material out that comes back not knowing this address. But once again, it's people doing the best they can to access a service that they think is going to be really useful to them. So we're kind of aware of that. But if we become aware of it once we're engaged in the therapy, then we just kind of practice acceptance, which is what we teach in DBT. What the heck? Okay, let's go there and good on them, and we're going to do the best we possibly can. We don't go, oh no, you shouldn't be here. You know, that would kind of be ridiculous. In terms, the majority of women felt they'd hit rock bottom when they were referred to the DBT program, described themselves as chaotic, desperate, insightless, no control, etc. You'd be aware of those kind of descriptions. Next slide. They were evenly split over which component they found useful. So DBT has two major components. There's the individual therapy and there's the group component. Where people are most ambivalent about is the group. Quite often saying, look, I don't want to go to group, I don't like groups, I don't want to have to get together with strangers, etc. That said, by the end, people generally really value the group. They value the relationships they've developed in the group. Often these are relationships which carry a level of understanding from a shared experience of the world, and unless they run the risk of there being some misuse in that, seem to be very powerful reinforcers. Discussion about the DPD after hours phone caused considerable distress. So one of the things that we offer is an on-call service from 8:30 in the morning till 10 o'clock at the night, 7 days a week, though we do close it down over Christmas. Now in terms of access to this phone, we have some rules. The first is that if you've self-harmed in the last 24 hours, you can't use the phone. We explain to this to people up front, and the reason we do it is we're fearful that in some shape or form we will reinforce the self-harming behaviour. So we're happy to have people ring right up to the moment of self-harming, though we'd much prefer people ring earlier, so we could look at kind of skills that they could use not to get that point. But we're just concerned. So there are other phone services they can ring. They can ring the psychiatric emergency centre, that sort of thing. But we're just saying that the DBT phone is not available for that 24-hour period. The other thing is the phone is only available to people while they're in the skills component of the treatment, and that's a 48-week period. Mostly runs for a year when you allow for bits of holidays along the way. And so some people really pine for that service because that's as close as we can get to kind of being in situ with people. They can ring us outside of hours, that sort of thing. Now we do it as a roster, so they'll get different staff along the way, so they'll get different information along the way. I mean, we're kind of consistent in our inconsistency, but we're all kind of coming from a DBT frame. So while some people struggle to use the phone, those who use it find it really helpful and then miss what has been something really helpful in their lives. As a whole, DBT was perceived as being extremely worthwhile while being confronting and frustrating, in particular the use of the diary card. So if you're in a DBT program, you have to fill in a card on a daily basis that tracks any self-harm, any urges to kill yourself, urges to self-harm, a range of quality of life interfering behaviours, and a whole range of emotions. I think both consumers and therapists alike find that card frustrating in various shapes and forms, but gee, it is a really powerful tool in terms of people developing an awareness of, and on the back of it they record skills, so it's very powerful in terms of developing an awareness about one's own emotional flow and the skills that one uses. It's also a very quick shorthand way for a therapist to get an overview of somebody's week, and we actually use it to set the agenda in the therapy. I've kept the diary card myself. We get anybody who we train to get to keep diary cards. It can be a bit frustrating building them into your life in various shapes and forms, but it's well and truly worth the effort. This is just a tip from a recent consumer. So here are my top 3 tips for getting the most out of DBT. Keep going until. It took a long time for me to see a huge difference to my life, kind of like putting together a jigsaw puzzle. You know how you cannot connect some clumps of pieces here and there and get glimpses of the picture? The DBT journey for me was like that. I could see parts of improvement along the way. It was frustrating that I couldn't see more for a long time, but the more time I spent practicing putting more pieces together, the clearer the picture became. So don't give up on that puzzle because it's a pretty picture at the end. And this is really was somebody who's just finished our program, and really a message she wanted to pass on to people coming into the program or coming after her. And one of the things that I think is really difficult about DBT is that initially there isn't a great deal of progress, and in fact life can actually get a bit harder, because essentially we're trying to work with people to get them to decrease some of the things that have worked for them, things like self-harm, while at the same time trying to put some skills in which initially don't make sense, to be honest. I mean, why would I use those when these things work for me? So there is a little bit of a risk that early on people's mood actually goes down, their coping goes down, and before you start getting a lift. And so there's a requirement really there almost to have a degree of faith. And so this once again is where the therapeutic relationship is so important. Am I going? Thank you. Okay, can I jump through? How much time have I got, James? And then I'll know what 3 minutes. Okay, so let's jump past the future. We're going to go to whatever comes after the future. That's not bad. If we can jump again. Keep jumping until we lose the future. We'll also lose this woman's journey. Sorry about this. One more. Okay, so in terms of getting this feedback, the question is, what do we do with it? And this is certainly one option, but decided it's mostly not the most appropriate, so we can go on to the next slide. Okay, so one of the things we did was we sought and got some nursing initiative funding. When we were running this training out, though, one of the people who was attending said, but shouldn't these people be treated in prison? So shouldn't people with borderline personality disorder be put in prison where they can be treated? I was just horrified. It's like I was talking to somebody from another planet. The one problem being, I obviously wasn't talking to somebody from another planet. I was talking essentially to a colleague in the mental health service in which I work, and I bet they weren't Robinson Crusoe. Oh, look, it just captured a real sad truth for me. It's the most extreme comment I've heard, which is why it's up there. But in that process, we trained 100-odd staff in a rural setting. So we trained across mental health, ED, community health, that sort of thing. All staff got 2 days of training in and around borderline personality disorder and a brief introduction to DBT. Then there was a subgroup who got 4 days of training, and they went on to set up a DBT program in that rural setting. One of the comments from the NUM, from the inpatient unit who was in that geographical location, is saying it changed the temperature on the ward. In other words, we went and trained the staff, and one of the things we trained the staff in was the assumptions that we use as therapists in DBT. And so the assumptions are things like, people are doing the best they can. People want to improve. The lives that they're currently living are horrible. So, in essence, by going in and teaching staff around this, what we found was that they were then more understanding, more empathetic to patients on a ward in general. And so what it did was it brought down the emotional temperature. It meant that the wards worked much better for everybody. So we were treating the staff, and that seemed to help. Go to the next slide. In terms of stigma then within mental health services, and we've heard about this throughout the day. So when we were doing this training 10 years ago, we felt it was imperative to add a section to our DBT training package on stigma. So we had a whole block of stuff we put in and around stigma. Because even with the people coming to DBT programs, so they were essentially coming on to learn how to work with people with borderline personality disorder, they were arriving with the stigma of the system kind of on their back. So despite the fact that they were making some decisions, that's what they were arriving with. We're rewriting our training package. This is about the 4th time we've done it now over about the 10 years or so, and we're removing the section on stigma. This isn't saying the stigma out there's gone away, but the people who are coming through the program now, in terms of being trained, aren't arriving with that stigma. And I'm really aware, and it's really kind of lovely to see. When I started teaching about postgraduate clinical psychology program, when I talk to them about stigma against people with BPD, they kind of look at me as if I'm coming from Mars, and it's so nice to come from Mars. So I'm aware that things are changing, but they're changing slowly. So while it's alive and well, what I'm aware of is that there's enough people coming through without that stigma attached that they are able to provide enough support to one another to kind of resist the pressure of the old hands. Because there is a lot of kickback, a lot of pushback from those people who maybe have been around for a bit too long, a bit too burnt out, they've lost their enthusiasm along the way. The other things we've done along the way, so we've set up a family and friends group. And so this is for anybody who's in our treatment programs for borderline personality disorder. We now run these twice a year. They generally have at least 20 attendees. There's got 8 sessions in them, and you can see the things there that we cover along the way. And when we're talking about family and friends, there was one person who lived in a group household, and so the 4 members of her group household came along for the 8-week program. It was just really lovely to see. And look, generally the feedback from that has been really positive, both from the consumers and the attendees. So often the people we're working with will say, look, it's been fantastic, you know, my parents now get me in a way they didn't before, or those sorts of things. So it kind of has a lovely backwards and forwards. In terms of choice now, we're offering 2 different models. So there was reference along the way to self-psychology or the conversational model. So as the service has now grown from 4.5 clinical staff to 10, we're now offering 2 models, which is just a recognition that, you know, one model doesn't fit all. So in terms of then of our growth now, we're running 4 DBT groups at a time now instead of 1. We've now got programs up and going both at Taree and Maitland. Half a dozen years ago, we had somebody travelling down from Taree or the other side of Taree, so a 2-hour drive to come down into 10 groups and go back. We just thought that we had to address that in some shape or form. Also in Taree and Maitland, in addition to the comprehensive DBT groups, and this is the more expensive version you're hearing about, we also run light groups, and those light groups will be people for borderline trainings or with other diagnoses along the way. Also in our geographical teams in Newcastle, Lake Macquarie, we run intermittent light groups, and many of our services now run DBT informed. So a lot of the skills that we're teaching DBT are generalisable to everybody. I'm just going to ignore James, I'll try and get to the end of this, sorry. But also in terms of trying to change stigma, change attitudes, get services to improve, we've run training internal and external to our service. We've run it across a number of states. We've done it public and private. We've done it into services. We've done it with individuals. We lecture the grand rounds. We do in-services. We teach into our undergraduate programs, postgraduate clinical psychology, postgraduate mental health nursing, and into our psychiatry training program. You know, if we're going to get change, then we've got to actually talk to ourselves as much as anything else. Hope I didn't get there too late. Okay, sorry that was a bit of a sprint.
Such an abrupt end. Thank you very much, Chris. Now, if Rachel could come back on.